when they're at high altitude, the FiO2 is actually decreased. Well, the partial pressure overall of oxygen in the air is the overall pressure is decreased, the atmospheric pressure is decreased, and therefore the oxygen pressure is decreased at high altitude. So at high altitude, the FiO2 would go down, which would decrease the P big AO2, which would decrease the P small AO2, which would then result in a state called hypoxemia. So that's one example. Another example would be to decrease the P big AO2. The classic way by which the P big AO2 decreases is anything that increases the P big A CO2. The P big A CO2 would actually decrease the PaO2, and that's because recall that there's a certain pressure that can exist, and it's a balance between oxygen, carbon dioxide, and nitrogen is a constant. So anytime the P big A CO2 goes up, anytime there's carbon dioxide building up in the lung, the PaO2 will always go down. They're always opposite. So what would be some examples where carbon dioxide would build up in the lung, which would then knock down the P big AO2? Hypoventilation, where carbon dioxide gets a chance to pile up in the lung because it's not being blown off. That's one example. Another example, which would cause this, would be COPD. In COPD, you're very, very familiar with the fact that air gets trapped within the lung, chronic obstructive pulmonary disease. Air is being trapped within the lung, and so that would also decrease the P big AO2. Now, once the P big AO2 goes down, then automatically the P small AO2 is also going to go down, and that's obviously going to be hypoxemia. Another way by which hypoxemia can occur, remember that the P big AO2, its goal is to squeeze blood into the capillaries of the alveolar air sac. So let's say that we thickened the alveolar air sac so that this pressure, the P big AO2, would not be able to squeeze as much blood into the capillaries. An example of that would be interstitial fibrosis of the lung. When there's interstitial fibrosis of the lung, the oxygen diffusion barrier increases or thickens, and therefore oxygen can't be squeezed very well into the blood. So that would be another example of how hypoxemia might occur. So again, I think if you understand the general idea here, it gives you a very good grasp on what we mean by hypoxemia. Now, obviously, anytime the P small AO2 here goes down, that's also going to decrease the SaO2, because this is the pressure that actually was creating the SaO2. And you can review your oxygen dissociation curves, and you'll see that to be true as well if you were to correlate these numbers on the oxygen dissociation curve. So I hope that clarifies the concept of hypoxemia. But the general principle that I'm really trying to get at here, aside from the physiology that I just mentioned, is hypoxemia refers to a low partial pressure of oxygen within the blood, and it's another cause of hypoxia, which is, again, the broad topic that we're talking about. A third way by which we could create hypoxia, or by which hypoxia occurs, is to have a decreased O2 carrying capacity within the blood. Now, in order to understand this, remember that the dissolved oxygen within the blood actually enters the red blood cell and then binds hemoglobin. And it's hemoglobin that actually has the role of carrying oxygen to the tissues and eventually unloading it at the level of the tissues. Recall from physiology that the vast majority of the oxygen content of the blood is actually due to oxygen bound to hemoglobin. And so if you knock out the red blood cells, or if you knock out the ability of the red blood cell hemoglobin to carry oxygen, that will also result in hypoxia within a tissue. Let's just give you a few examples of that to highlight this idea, and because this one of the few places we'll get to discuss this principle. One example of a decreased O2 carrying capacity of the blood would be anemia. Remember that anemia refers to a decrease in the total red blood cell mass in the body. And when there's a decrease in red blood cell mass, there's going to be a decrease in the amount of oxygen being carried in the blood. And therefore, if there's a decrease in the amount of oxygen being carried in the blood, there's obviously going to be a decrease in the amount of oxygen going to the tissues, i.e. hypoxia. And so one important thing to remember is that if we go back to our paradigm that we had just established, if you have an FiO2 and the FiO2 is generating a P big A O2, and that's generating a P small a O2, and that's eventually going to generate an SaO2. What we should remember is that when we have anemia, there's no problem with the the atmospheric oxygen. There's no problem with the ability to bring oxygen into the lung. There's no problem with the ability to squeeze oxygen into the blood. So the PaO2 is actually normal. At the same time, the SaO2 is normal as well. And the reason the SaO2 is normal is because hemoglobin, the SaO2 just looks at what percentage of the hemoglobin is bound by oxygen. And so if you have, if you've got, I don't know, let's just pretend that I've got 3 red blood cells in my entire body, and each red blood cell is carrying 4 molecules of oxygen. In that case, I'm 100% bound because each cell has the ability to carry 4, and each cell is actually carrying 4. Now, if I get an anemia, let's say that I get an anemia and I knock out 1/3 of my red blood cells, each of my remaining blood cells is still carrying 4 molecules of oxygen. And so here I'm again 100% bound and 100% bound. So the SaO2 does not, because it looks at the percentage of the percentage of oxygen molecules that are bound to hemoglobin, it's not going to be altered in an anemia. So I hope that's clear. Another way by which we can have a decreased O2 carrying capacity of the blood is carbon monoxide poisoning. And this is a very high yield topic for examinations. And so let's briefly review this. The idea here is that carbon monoxide is a very avid binder of hemoglobin. It binds hemoglobin 100 times more with a 100 times affinity as opposed compared to oxygen. Now, carbon monoxide is actually an odorless, colorless gas, and it can sneak into the lungs, and then it can bind the hemoglobin, and once it binds the hemoglobin, it doesn't let the hemoglobin go, and therefore oxygen can't bind. Now, in this particular case, the PaO2 will be normal. Again, there's no problem with the FiO2, there's no problem with the Pa big O2, and there's no problem with the P small aO2. And so therefore the PaO2 will not be changed. It will be normal. However, the SaO2 will be decreased. And the idea here is that if you've got a red blood cell and it normally has the ability to hold 4 hemoglobin molecules, but let's say it can only hold 2 because of the fact that the other 2 spaces are bound by carbon monoxide, that's going to be a reduction in the percentage of spaces that are bound by oxygen, and so the SaO2 will actually be decreased. Now, important to recognize for examination purposes and for clinical purposes, the common exposures that lead to carbon monoxide poisoning include smoke from fires. So any patient that happens to be, let's say, exposed to smoke from a house fire or some fire of that nature can develop carbon monoxide poisoning. Another important source of carbon monoxide poisoning would be exhaust from cars, and this is the classic example of a patient who might try to commit suicide by carbon monoxide poisoning, where they start their car and they shut the garage door, and the carbon monoxide slowly builds up within that closed space. And then third way by which carbon monoxide poisoning can occur is via gas heaters, and that's a relatively high-yield sort of clinical scenario that can show up on exams. The classic finding in a patient with carbon monoxide poisoning is cherry red appearance of the skin. The reason the skin looks cherry red is because the hemoglobin is so tightly bound that it creates reflects the red light and allows and creates this red appearance to the skin. However, it's deceptive because the patient actually is actually hypoxic because they aren't carrying oxygen to their tissues. So although they look very red, they're not getting good oxygen delivery to the tissues. Now, another important point here, and it's kind of high yield, is when you look at most textbooks, they'll actually list the various things that occur in stages as carbon monoxide poisoning occurs. For example, the earliest change is headache, and then the patients can get confusion, etc., until eventually it leads to coma and death. Now, the leading of carbon monoxide poisoning to coma and death shouldn't be difficult for you to remember because, as I told you, it's a mechanism by which patients commit suicide, or an individual could commit suicide. And so I don't think that's hard to remember. But what is very important to remember, especially for examination purposes, is the fact that the early sign of exposure is headache. And I guess this would also be important clinically, because if you've got a patient that has been exposed to a fire or comes in after some type of exposure and you want to screen, just a very quick clinical history screen, you can ask the patient, do you have a headache? Or if the patient complains of a headache, you really want to then sort of raise carbon monoxide, the worry for carbon monoxide poisoning, especially with an exposure. So for examination purposes, I would say very important to remember that an early sign of exposure is headache. A third way by which we could decrease the O2 carrying capacity of the blood is called methemoglobinemia. The idea here goes back to a little bit of biochemistry, so this is why it becomes high yield. Again, examiners love to take biochemical principles and when they apply to clinical scenarios, it's a great way to test. So these things become very high yield. You don't really see methemoglobinemia very commonly except on examinations. So the idea here is that remember that the heme in hemoglobin actually contains iron. And that iron is normally in an Fe2 plus state. Now the Fe2 plus is what binds O2. And I usually tell my students that this is very easy to remember. Fe2 binds O2. Fe2 binds O2. So if the Fe becomes oxidized and goes into a 3 plus state, then Fe3 plus is not able to bind O2. So if the iron in the hemoglobin becomes Fe3 plus, that is called methemoglobinemia, and the hemoglobin is no longer able to appropriately carry oxygen. Now in this particular case, the PaO2 would be normal, and we've already covered this. There's no change in the FiO2. There is no change in the P big AO2. The lung is able to fill and gather oxygen and blow off carbon dioxide appropriately, and so therefore the PaO2 in the blood, the partial pressure of oxygen within the blood, would be normal. The SaO2, however, is decreased because if you've got a red blood cell, and the red blood cell again is only able to carry, for example, 2 molecules of oxygen instead of the normal 4, that would be a 50% saturation, and so the SaO2 would be decreased. Now, the next point to be aware of in this context is in what clinical context would we actually see methemoglobinemia? And classically, it's seen with oxidant stresses. Oxidant stresses would actually have the ability to oxidize the iron. So what are some oxidant stresses? Well, sulfa drugs are oxidant stresses. Nitrate drugs are oxidant stresses. Those are the classic ones, and those are the way by which they tie in a little bit of pharmacology on examinations. Another group of patients that can actually develop methemoglobinemia are newborns. Now, in order to understand that, you should probably go back and remind yourselves that we're always oxidizing iron within hemoglobin, and all of us within our blood probably have a very tiny percentage of methemoglobin floating around in the blood. And that's because the blood carries oxygen, and there's an oxidant stress that's constantly present within blood. And so physiologically, we actually have enzymes that participate in creating the mediators necessary to reduce oxygen back to its 2 plus state. Reduce iron back to its 2 plus state. Now, newborns, their machinery to be able to do this is a little bit immature. And so newborns are particularly susceptible to the development of methemoglobinemia. The classic clinical finding in methemoglobinemia is chocolate-colored blood. Chocolate-colored